So again, to make you understand, before you do the procedure, the pre-contrast supine radiograph showing there is no evidence of any radiopaque shadows. And then they have taken the first image, the right anterior oblique. There is smooth passage of the contrast from the anterior urethra as well as the bulbar urethra. Then you have your one more left anterior oblique. You can see the contrast entering into the membranous part as well as the small stream is noted in the prostatic. Usually you're supposed to see contrast entering into the urinary bladder also, right? So this is again, the more and more thoroughly you're seeing the anatomy, you would not make mistakes in identifying the pathologies. So this is the anterior penile urethra, the bulbar urethra, the membranous, and this is a prostatic urethra as well as contrast is seen entering into the urinary bladder, right? So this, I'll just share a few images now which will tell about the improper techniques when you're doing the procedure. So if you're not stretched the penis completely, this is the type of abnormality you would be seeing because of improper stretching of your urinary, not improper stretching of the penis. So once the penis is stretched completely, this is how your contrast film will be noted. That is the anterior urethra, this is the bulbar urethra, membranous, and the prostatic urethra. This is the correct positioning and the correct stretching of the penis. If it is not stretched, this is how the abdomen will be seen. Okay. Again, in this procedure, what we are seeing, because of this effect of stretching, you're able to see the complete filling up of the urethra with the contrast. If you are not stretching it completely, it appears there's a small stricture or kinking, something like that. Okay. So be careful while doing the procedure. You need to hold the glans penis and stretch it completely and then instill the contrast. Otherwise, there's always a chance mimicking like a stricture formation, right? What is the mistake happening over here? You are seeing there are few air bubbles. This should never happen when you're injecting the contrast. Once you load the contrast and once you are instilling the reconstituting with normal saline, see to that there are no air bubbles in the syringe. Without air bubbles, you're supposed to inject the contrast. Usually it won't cause any problem, but still the procedure will not look good if there are air bubbles within the urethra, right? So see to that there are no air bubbles for injecting the contrast. And then the common normal anatomical variants in the RGU. This structure, what you're seeing here near the bulbar urethra, is a Cowper's duct. This is a normal filling of a Cowper's duct. Do not mistake this for an extravasation. And this here is a Litter's gland. This is commonly seen in an anterior penile urethra. Do not confuse this with abnormality. Sometimes you might see, because excess pressure, the filling of your prostatic ducts. So don't confuse this with extravasation, or there is a contrast has gone beyond the urethra. Don't confuse it with that. This is a prostatic urethra, is filling of the prostatic ducts by the contrast, which is a normal thing. And then the first and foremost, always I've told you, do always a plain radiograph of the pelvis to look for any radiopaque calculus. You are seeing a calculus in urethra, which is confirmed on instilling the contrast in RGO procedure. So if at all you're seeing a calculus, and then if you see the injected contrast, there will be lucency. Okay. So most important is, like, before doing the procedure, never directly do the procedure without doing a plain radiograph. Plain radiograph will help us to identify if there's any foreign body or any calculus in the urethra or the urinary bladder, right? Now coming back to the pathologies, what are the commonest pathology we're going to see is strictures. As I told you, strictures, you need to know the commonest cause will be gonococcal urethritis or a trauma or a instrumentation. These are three commonest. Now first we'll think about commonest infection. There is urethritis, and you can see there are multiple strictures in the anterior urethra, as well as like pan urethritis is called, because involving the anterior penile urethra in the part of the bulbar urethra. It is irregular filling over here. It's not like smooth filling. As you compare the previous RGU, this is called as a smooth filling of the urethra. Okay. Here you're not seeing the smooth filling. There is narrowing as well as irregular noted in the mucosal pattern, which indicates is a urethritis. And then again here, you can see a long segmental urethral structure noted in the distal part of a bulbar urethra. The anterior part is normal. You can see the smooth filling with distension of the urethra. As you come beyond the anterior penile urethra beyond, you can see the bulbar urethra. There are multiple structures narrowing and irregular noted in the bulbar urethra. There's a long segment urethral structure noted in the bulbar urethra. So one more pathology you're seeing. You can see there's a smooth filling of the contrast in the anterior urethra, and there is the proximal bulbar structure you can see over here. The distal bulbar is fine. The proximal bulbar urethra, you can see there is a structure formation over here. So this is a classical case of a bulbar urethral structure in a RGU, right? So here also you can see the bulbar urethra is neatly opacified, whereas the anterior penile urethra, the caliber is reduced, the lumen caliber is reduced, as a multiple irregular filling defects are noted, right? There is opacification litter glands. That is a normal thing, but you can see the penile urethra caliber is reduced. Okay. And then sometimes when you do a study like this, you see like this, it's just a post-brachytherapy, the severe structure of the entire urethra, not only the anterior part, even the posterior, there is a prostatic, membranous, bulbar, and the anterior, the entire urethra, there is narrowing because of the post-radiotherapy changes. Okay. So I told about the contrast intravasation. Sometimes when you put more pressure, there always a chance of contrast entering into the dorsal vein of the penis. So to be careful, do not put more excessive pressure. That is why always better to use a non-anemic contrast, even if there is intravasation of the contrast into the dorsal vein of the penis, it will not cause any harm to the patient. Right? Same like using an IV where the contrast you're going to inject to the vein. This contrast will go into the vein, it will get absorbed and get excreted. Okay. So this is a case of a gonococcal urethral structure. You can see the complete long segment irregular beaded narrowed appearance of the entire penile urethra. Entire anterior penile urethra, the bulbar, the membranes, as well as the posterior urethra, there is a beaded type of narrowing. So two commonest things you need to think. One of the commonest infection for a beaded is usually gonococcal urethral structure. The other DD, if it comes gonococcal negative, any of the culture or blood test or whatever, then you have to think of tuberculosis, right? So this was a case for periurethral abscess. You can see there are irregular beaded narrowing of the bulbar urethra. There is opacification of Letter's glands, and there is irregular periurethral cavity originating from the ventral aspect of your bulbar urethra, and there is large collection of the contrast. So this was a case of periurethral abscess communicating with this bulbar urethra. Okay, don't think this sometimes as an extraversion of contrast. So extraversion will not have a collection like this. If there is any communication from the urethra to the abscess cavity, this is how it will appear as a periurethral abscess, right? Now coming to the report, how we are going to do. So retrograde urethrography report, whenever you start writing, always mention the procedure, how it has been done. And I said precautions, 20 ml of diluted contrast media certain. So I have not mentioned specifically what contrast. You can mention whether you used ionic contrast or a non-ionic contrast, what was used. It was injected in urethra and Syrian films were taken. So findings, very important, always mention, start with your anterior and the bulbar urethra, how it is seen. There is normal in caliber or reduced in lumen caliber or irregular in the mucosal part. Then comment on the stricture is there or not. Then comment on the membranous urethra. It is a very short, small segment. Noted in the posterior urethra, it is normal or in a stricture. And then come back to the posterior urethra, which is the prostatic urethra, which is up, is normal or any reduced in lumen caliber. You need to comment. So if there is no abnormality, you need to mention no signal abnormality is noted at present study, right?